Welcome back. In previous lessons, we've looked at how asthma control is assessed and the medications that are involved in therapy. Today, we will look at what to do when your patient comes back for a follow-up visit and when therapy adjustments are warranted. By the end of this lesson, learners will be able to choose the appropriate pharmacologic intervention in both the escalation and de-escalation of therapy based on the patient's level of asthma control. They will understand the appropriate length of time pharmacologic intervention should be trialed before determining treatment failure. They should be able to identify modifiable factors that contribute to poor asthma control and recognize when referral to a specialist for care is appropriate. As a reminder, this lesson is not all-encompassing. It is meant to give you the most high-yield information. For further information on asthma severity, visit the Resources tab on our website, where the EPR4 and GINA guidelines have been made available. First, let's start with a clinical scenario. Gina, your 10-year-old female with moderate persistent asthma, arrives in your office for an asthma follow-up. She was started on a daily inhaled corticosteroid 8 weeks ago. She's strictly compliant with her ICS. Despite this, she's still having daytime cough 3 days a week that requires her to use her albuterol. She has some difficulty keeping up with her friends during play, but the albuterol helps. Coughing at night wakes her up about once a week. She hasn't needed oral steroids since she was last seen. How controlled is Gina's asthma, and how would you adjust her therapy? In previous lessons, we've learned about diagnosing asthma and its severity and the initial patient visit. We've also looked at how to assess control, but what do you do with that information? At your patient's initial follow-up visit and every subsequent visit, you will have the opportunity to reassess their asthma control and make adjustments to their asthma therapy. So how long do we wait to assess asthma control? Typically, anywhere between 2 and 6 weeks. This is the minimum time needed to determine if the current therapy's level of effectiveness. It's important to note, however, that if your patient's asthma seems not well controlled, looking for modifiable factors is important before deciding to step up their therapy. Those factors could be anything from their adherence with their daily controller, inhaler technique, environmental factors such as secondhand smoke exposure in the home, or untreated comorbid conditions such as allergic rhinitis. At the follow-up visit, if there are no modifiable factors contributing to your patient's poor asthma control, stepping up their therapy may be the appropriate next step. But what if their asthma is well controlled at their initial follow-up? Can we step down their therapy? Not quite. No matter the patient's age, we usually don't like to consider de-escalation of therapy until a patient's asthma has been well controlled for at least 3 months. So, when we talk about stepping up and stepping down therapies, there are specific guidelines that help you in your clinical decision making. But before we look at that table, I wanted to break down asthma management into its simplest form. When we talk about strictly as-needed asthma care, the main drug class that will be used are the SAPAs. When we talk about daily controllers, it will either be the inhaled corticosteroid monotherapy or the ICS-LABA combined inhaler. And when we talk about one single inhaler to do both as needed and daily controller therapies, the ICS-LABA, specifically a formoterol containing combined inhaler, is the only class of medication available for that. The table provided shows a stepwise approach to asthma management. As you can see, there are 6 steps divided by age ranges. It's important to note that this table is only giving you the first-line therapies for asthma management. There are alternative options, as not every person's situation or insurance will allow them to use the below prescribed therapies. It's also worth noting that while there are 6 steps in management, as a general pediatrician, you will often only be responsible for managing the first 3, sometimes 4 steps of therapy. If your patient is requiring step 3 or step 4 of asthma management, you should consider referring to an asthma specialist. Because of this, let's only focus on the first 4 steps of management. So, when looking at this simplified table, there are a few things that you will notice. First, regardless of age, step 1 of therapy for intermittent asthma involves just as needed SABA therapy. If your patient has intermittent asthma, they should not require a daily medication. In step 2 of therapy, the lowest step for patients with persistent asthma, regardless of age, a daily low-dose inhaled corticosteroid with as-needed SABA is the treatment of choice. What you will notice for this step and steps 3 and 4 is there are low versus medium dose formulations for these medications. If you go to the Resources tab on the Asthma Curriculum website, there you can find specific dosing levels for your patient's specific age. When we get to step 3 of asthma management, here's when we start seeing the recommendation of using a daily and PRN combined ICS-LABA as management for ages 5 and older. It's worth noting, however, that officially combined ICS LABAs using formoterol is only approved in those 6 and older. Anecdotally, however, we still use it in 5-year-olds. For children 5 and older, you can consider using a daily medium dose ICS with PR and SABA if you do not feel comfortable with managing combined ICS LABA, or if your patient's insurance doesn't cover the combined inhaler. This is also the step that you can consider referring to an asthma specialist for management. Lastly, we will specifically list an ICS formoterol combination inhaler as the drug of choice for both daily and PRN use because formoterol is the fastest acting LABA and currently the only one approved for use in the pediatric population. The final step you should be familiar with is step 4 of therapy. In this step, you may be prescribing a medication, but you should absolutely be referring your patient to an asthma specialist for their ongoing asthma care. At this step, ages 4 and younger will begin to utilize a daily ICS LABA while still having an as-needed SABA. Ages 5 and older can use a medium-dose ICS formoterol formulation for both daily and PRN use, or can consider high-dose daily ICS with an as-needed SABA plus another add-on therapy. Let's go back to our clinical scenario. We know that Gina is a 10-year-old with moderate persistent asthma and is currently strictly compliant with her daily inhaled corticosteroid. Despite this, she continues to have asthma symptoms 3 days a week and a weekly nighttime cough. Based on this, we can classify her asthma as not well controlled, and we can consider stepping up her therapy from step 2 to step 3, a daily and as-needed inhaled corticosteroid formoterol combined inhaler. So, as we finish this lesson, there are a few things you should remember. First, regardless of what step of asthma management you start on, you must give your patients time before determining if they have failed that level of therapy and need the next step of management. If your patient's asthma does not seem to be well controlled, look for modifiable factors that may need to be addressed before deciding to change therapies. Lastly, referring to an asthma specialist is always an option and sometimes the right next step, but having a basic understanding of how asthma is managed and how to modify your patient's therapies is vital to ensuring that they are receiving the best and most timely care. Now, head to the practice section in the asthma curriculum website to continue learning how to modify your patient's asthma therapies.